السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. نبدأ هذه المحاضرة. This lecture about the WHO Labor Care Guide. دكتورة بان هادي، كلية الطب الجامعة المستنصرية. This lecture is directed to the 6th-year students so that they can learn how to fill the WHO Labor Care Guide, and this presentation contains clinical cases, how to apply and how to make a decision guided by the labor care guide. First, it is designed for the health personnel to monitor the well-being of the mother and the baby during labor, so that any deviation from normality will be recorded and alerted to the manager of the labor. This is the labor care guide, contains 7 sections as you see in this picture, and you can print this graph so that you practice the exercises in this presentation. The aim is to stimulate a shared decision making so that promoting healthy woman and healthy baby. This decision shared by the woman and the healthcare provider. The main aim is ensure safety and avoiding unnecessary interventions and provide a supportive care. For whom we use the labor care guide, it is used for apparently healthy pregnant women in the low risk pregnancies. However, those at high risk groups should manage by additional specialized monitoring and additional supportive care. When should be initiated? The labor care guide should be initiated when the cervical dilatation reach 5 cm or more. Thus, to mean in the first stage of labor, the woman should have regular painful contractions and she should be in established labor. This is the first difference from the previous WHO partograph, which started at 4 cm cervical dilatation. Where should it be used? It can be used in all health facilities, including primary, secondary, and tertiary centers where they care for laboring women. The structure of the labor care guide, it contains 7 sections, as we see here. The first one about the woman characteristics, the supportive care, the third one the baby, then the woman, then labor progress, medication, and shared decision making. The supportive care and the shared decision making is the second and the third difference from the previous WHO partograph. As we see, this is section 1, name, parity, labor onset, active labor or not, time of rupture membranes. Section 2, this is the supportive care, and the 3 is the baby, and 4 is the woman. Here 5, the labor progress and medication, and here the shared decision. Whereas the previous WHO partograph, it contained of 4 sections. The first section about fetal condition, then labor progress, then the mother, and the general information in the beginning. So, the woman name, time of admission, date of admission, mode of labor, time of rupture membranes, and we concentrate here that we start labor care guide for the woman when she is in active labor. Active labor is defined as regular, painful uterine contractions bringing about cervical change in form of dilatation and effacement. When the woman reaches 5 cm, here we start plotting on the labor care guide. Here first, the name, parity, labor onset, active labor diagnosis, ruptured membranes. If the woman has ruptured membrane, we write the date here, the time. If no, we write no. And any risk factor should be written here. This is the time in local time, whether 12 or 24-hour systems. And here the number of hours since admission. This is the first hour, second hour, third hour, and so on. Here we see there is the active phase of first stage of labor, and here the second stage of labor. You see, this is the fourth difference from the WHO bartograph. WHO bartograph contains no second stage of labor, only first stage. Okay. This is the alert column and applied for the whole graph for all the 7 sections. Okay, so that anything abnormal here, okay, we should encircle it with red. This is section 3, the fetal condition, the maternal condition, labor progress, and section 5, and here the medication and shared decision making. Okay, instructions. Any observation made the criteria for alert should be encircled so that we be alert and continue the management, whether it is routine management or we need any additional care. If the labor extends beyond 12 hours, that's to say the patient past the 12 hours for the first stage, we can use a second paper for labor care guide. These are the abbreviations that we can use it during this presentation. How to use it? The most important thing is that first we assess the condition, then we record it, and we check in the reference for the alert line, and then we plan our approach for the management. Assess the mother and the baby, progress of labor record, document on the graph, check the reference threshold. For each recording, you should go to the alert column and see if this an alert sign, you should encircle it with red. And then plan further decision and further management based on our finding. And this is personalized for each patient separately. Okay, the time axis. Define first the time in local time and the hours since the time of admission. Each column 1 hour, whether 12 hours or 24 hours can be applied. Okay, here let's take this example. Our patient admitted at 6:30. This is time, and this is the first hour. Then 7:30, then 8:30, and so on. At 12:30, the last record in the first stage of labor. Then, when we examined her at 12:45, she was fully dilated. This means that she entered the second stage of labor. So here we transfer the time into the second stage and we complete the plotting in the second stage of labor. The alert column, as we say, any finding during whole record means the alert column, we should encircle it and make a proper decision. Okay, here we see rupture membranes, date, time, or unknown. For example, we examine the patient and we find she has a rupture membrane. We write unknown. Companionship, there should be someone present, supportive care for the woman. If yes, yes, and no, no companionship. And if the woman declines, she doesn't want someone with her, so we respect her preferences. Pain relief, yes, no, and if the woman declines, again. Oral fluid, yes, no, or if she declines. The posture, supine, or she's mobile, and she mobile, it means she can take any position she wants. Standing, sitting, left lateral, go and down, and squatting, any position. Fetal heart deceleration, either no deceleration or early late variable deceleration. About the membranes, is it intact membranes or ruptured with a clear liquor, or there is meconium? And if there is meconium, is it 1 plus, mild, non-significant with adequate liquor, or it is 2 pluses, medium or thick, scanty meconium, this is 3 pluses. Blood stained, B. Occiput anterior, we write A, which is the normal, but the mild position is the P, occiput posterior, and the T, the transverse. The caput 0, 1 plus, 2 pluses, or 3 pluses, that is marked caput. And molding 0, 1 plus, sutures just opposed, so that we cannot feel the sutures. The bones are approximated, the sutures overlapped, and the bones are reducible. And here the bones overlapping each other but non-reducible. This is the significant, the 3 pluses molding. Urine, either no protein or a trace, or 1 plus, 2 plus, 3 pluses, and again for the acetone. Okay, oxytocin, yes or no? And if yes, you should write the units and the drops. Medication, yes or no? And IV fluid, yes or no? Okay, how to complete this section? Let's take this first example. Mary Jane, she is para 2, labor onset spontaneous, active labor 6 of July, and ruptured membrane 6 of July, the time 5, risk factors, history of stillbirth, and anemia. This is the first section, which is the patient characteristic. Another example, Mariam Ahmed, she is para 5, labor induced with prostaglandins or oxytocin, active labor diagnosis 28th of March, ruptured membranes 28th of March at 5 o'clock, the risk factors, preterm, preeclampsia. Okay, how to complete section 2? Companion, pain relief, oral fluid, and posture. All these included in the supportive care for the woman. The companionship, if first assess the woman have a companion with her or not. If yes, record yes. If no, no. And if the woman decline, write D. The alert, if no, if the woman has no companionship, so we should advise her to have a companionship, because this will prevent dystocia and will enhance her pain tolerance. What about the pain relief? If the woman taking pain relief, yes. If no, no. And if the woman decline, decline. If no, set alert. So we encircle with red and advise her to take analgesia in form of epidural or any opioids, so that to minimize the pain during labor. As we say, the woman is 5 cm and more, so definitely she needs pain relief because she is in active labor. What about the oral fluid? Oral fluid, yes, no, or the woman decline. If the woman not taking any oral intake, we should advise her to take light diet and soft drinks. The posture, supine or mobile. If the woman is supine, this is alert. We should change her position. This supine position may cause supine hypotensive syndrome and fetal distress. The woman can choose any position, left lateral, squatting, kneeling, standing, any position she can adopt during the first stage of labor. How to complete this section 2? Let's go to Mary again, which is admitted at 6. In the first hour of labor, there is no companionship, so we encircle with red. The pain relief, she is not taking any medication, so encircle with red. Oral fluid, yes, so this is normal. Posture, mobile, okay, this is satisfied. Later, after another 1 hour, companionship, yes, okay. Pain relief, yes, okay. Oral fluid, yes. So all these are normal and expected observation. But the position now is supine, so we should encircle with red and advise her to change her position. Another example, let's go to Mariam. Here at time of admission, 9:30. There was no companion, so encircle with red. Not taking any medication for pain relief, we encircle with red. The oral fluid, yes, okay, yes. Supine, so encircle with red and advise her to change the position. Here, again, no companion, so still we are encircling. This is after 1 hour, 10:30. Yes, pain relief, yes, oral fluid, she is mobile, and this is good. Here, the companionship is present, so yes, yes. The oral, no, so we advise her to take light food, and here, no. Supine, again, should be encircled. Note that these informations should be plotted in each hour, okay? In each hour, we plot the whole columns, and we, after assessment, we record and then initiate the plan. What about section 3? Section 3, the fetal heart baseline, any deceleration, amniotic fluid, fetal position, caput, and molding. Here first we assess, listen for the fetal heart, and we should continue after the contraction for 30 seconds or even 1 minute if there is any suspicion of abnormality. Record the baseline fetal heart and record if there is it normal or not. Okay. And the frequency of fetal heart monitoring every 30 minutes, not every 1 hour. So here the threshold check if alert if less than 110 or equal or more than 160. Less than 110 indicate fetal bradycardia, so we should change position, give oxygen, ask for supportive care. And equal or more than 160 indicate tachycardia, could be fever, could be dehydration, could be fetal distress. The decelerations, listen to the fetal heart minimum of 1 minute after the contraction, okay? And continue during a contraction and continue for 30 seconds after a contraction. If there is no deceleration, write no, early deceleration E, late L, and variable V. The alert is the late deceleration. So if we see late deceleration, we encircle with L, and late deceleration or a single prolonged deceleration, this indicate fetal distress, and we should conduct the emergency management of abnormal fetal heart. Well, the amniotic fluid now, the state of membrane, is there leakage? Yes. What about this? Or it is intact? I. If ruptured with the clear fluid, C. If membrane ruptured with meconium, M. Either 1 plus or 2 pluses or 3 pluses according to the severity or the thickness of meconium, and membrane ruptured with the blood-stained lacquer, B. The alert is M, 3 pluses, which indicate thick meconium. Okay, so it needs a close monitoring of the fetal heart. And if a blood-stained lacquer, again, this is an alert. So this may raise suspicion, could be abruption, okay, could be vasa previa, could be placenta previa. What about the fetal position? Normal position is the occiput anterior, so we write A. The abnormal is occiput posterior and occiput transverse, so we check the alert P and T, and here we should follow local clinical guidelines for management. What about the caput? We assess the caput either 1 plus, 2 pluses, 3 pluses. The alert is the 3 pluses, which may indicate difficult or obstructed labor. The molding, again, from 0 to 3 pluses, 0, 1 plus, 2 pluses, this indicate molding, and the 3 pluses, this is the alert, overlapping bones that are non-reducible. So this may indicate obstructed labor. As we see here, put in mind that these observations concerning the fetal condition are made every 4 hours because it is conducted with PV examination, and as we know, the PV examination is recommended every 4 hours in normal labor if there is no other abnormality. We go for Mary Jane again. We see the baseline fetal heart. They record every 30 minutes. You see, here we said every 1 hour. So here, no, it is every 30 minutes. The baseline 140, 136, 132, 148. This is normal. What about deceleration? No, no, variable, no. All these are, we record, and then we check with the reference. Only the late deceleration, we mark it as red, so we have no problem here. What about the lacquer? It is clear, so okay. What about the position? It is occiput posterior. Here we should plot the circle because this is abnormal. This is in the alert column. And the caput, no. Molding, no. Next example is the Mariam Ahmed. We see this is the fetal heart at first half hour 120, then it become 100, and this is abnormal. We should encircle. 140, 120 is okay. Fetal heart deceleration, no. Variable, no, okay. What about the amniotic fluid meconium with the three pluses? So we should plot a circle. This is an alert finding. What about the position towards occiput transverse? So we should encircle. No caput, no molding. Put in mind that these observations every 4 hours with vaginal examination, or we may conduct the vaginal examination earlier. If we see abnormality, sometimes we examine after 2 hours rather than 4 hours. So these records with vaginal examination, but these records should continue every 30 minutes, and if there are abnormalities, we should go on for continuous monitoring. How to complete section 4 for the woman? Assess the pulse rate. Check the threshold. If less than 60, more than or equal 120, we know in pregnancy the baseline pulse rate will be increased by 10%. So in the normal individual, between 60 to 100 is normal. During pregnancy, it will be raised by 10%, approaching 120, still considered as normal. So if pulse rate less than 60 or equal or more than 120, here we should follow the local guidelines. This may indicate abnormalities, but if the pulse rate is normal, we should continue the monitoring every 4 hours. What about the systolic blood pressure? Record the systolic blood pressure and check with the alert. If less than 80, equal or more than 140, this indicates abnormalities. And if it is normal, we should check every 4 hours. What about the diastolic blood pressure? It should be equal or more than 90. However, this is the alert, equal or more than 90, the alert. The normal should be less than 90, and we check every 4 hours. The temperature, axillary temperature is recorded normal up to 37.5. If it is more, this indicate an alert, so we encircle with red, and we should follow the local guidelines. However, if the temperature is normal, check every 4 hours. Urine, you record again if there is any protein or acetone. The alert is protein 2 pluses and more, and acetone 2 pluses and more. This may indicate dehydration, diabetic ketoacidosis, and so on. If the finding is normal, here they record every 4 hours. You see, let's go to Mary again, and let's see the maternal observation. Pulse rate 88, so normal, recorded after 4 hours. Blood pressure 120, 80, 36.5, negative protein and acetone, so we repeated after 4 hours. Let's see Maryam. Here her pulse rate is 90, but later on it is 130, so this is tachycardia. This is abnormal. We recorded with red. The systolic blood pressure reached 140, so we encircle with red. This is the alert. We compare with the alert line, so anything fill this criteria should be plotted and assessed. The systolic blood pressure, diastolic temperature, and the protein. Once it becomes positive, we encircle with red. Okay. What about the labor progress? We check the frequency of contractions, number of contractions in 10 minutes, the duration of each contraction, cervical dilatation, and the descent. Here first we assess, record the number as we said, and check. If the number 2 and less, this is inefficient contraction, we may need to give oxytocin. And if the contractions more than 5, these are frequent contractions that need a special alert. Okay, the checking of contractions every 30 minutes. What about the intensity of contraction? Less than 20, this is inefficient or inadequate, and more than 60, this is tetanic contractions. The cervix, you should check the cervical dilatation. Plot X in the cell that match the cervical dilatation number, and here check the threshold. If 5 cm remain for 6 hours and more, you should encircle. This is abnormal progress. At 6 cm, 5 hours and more, this is abnormal. At 7 cm, 3 hours and more, this is abnormal. So any abnormalities we see here, check with the threshold, we should encircle with red. What about the plan? If we see poor progress in labor, we should follow the local guidelines for the management. What about the descent? Assess the descent by abdominal palpation. We feel how many fetal parts of the fetal head is felt above the symphysis pubis. If we feel 5 fingers, this is 5/5 palpable or floating, or 4/5, 3/5. We plot as a circle in the corresponding cells corresponding to the number of fifth palpable abdominally. Okay, and we manage accordingly. There is no reference threshold for this because we know in multiparous women the head may remain floating until advanced labor, and still it may engage and deliver easily. They record this with every 4 hours with vaginal examination or otherwise indicated. Let's go to Mary again. We see here this is the fetal position, posterior recorded, then become transverse, then become anterior, so this is good. The caput 1 plus is not plotted, 1 plus, 1 plus, 2 pluses, again only the 3 pluses are considered significant. And then Mary entered the second stage of labor at 13.5, 13 she was in the first stage, and then go in the second stage. In the second stage, recording the fetal heart 145, 128, 118, this is normal. No deceleration here, early deceleration, okay. This is not alert, the alert only the late deceleration, and here the patient gives birth to a normal baby. Here these are the vital signs of the woman, and here the contractions, the 3, 3, 3, 3, okay, and all this normal, and the duration of contractions, okay. What about the dilatation? The patient at time of admission, the cervix was 5 cm dilated, so we plot X at 5, and the head was 4/5 palpable, we plot circle at 4. After 4 hours, this is second hour, third hour, 4 hour, after 4 hours, the cervix become 8 cm dilated, so this is good, normal progress, okay, and the head descend more, 3/5 palpable abdominally. After another 3 hours, the cervix is fully dilated, and the head is 2/5 palpable, so she's transferred in the second stage of labor. P, it means pushing. When she started pushing, here we write P, and the head is null palpable abdominally. So this is normal progress of labor. Let's see what about the other example about Maryam. Her contractions were 3 at time of admission. Okay, and it was good within the normal values, but after 1.5 hours only 2 contractions, so this goes with alert, so encircle with red. 3, 3, 4, 4, 5, and here it is 6 contractions, so these are frequent tachysystole. What about the intensity of contraction? 30, 40, 40, okay. 70 is, again, this is a hypertonic contraction, so encircle with red. What about the cervical dilatation? X at 7 cm cervical dilatation at time of admission. You see this is the vertical, is the time, and here the numbers represent the cervical dilatation. So I should plot, this is X. Then after 4 hours, she remained at 7 cm dilatation. I check the reference, if equal or more than 3 hours, I should encircle with red, so this is abnormal, so I encircle with red. What about the head? Is 4/5 palpable at time of admission. After 4 hours, it become 3/5 palpable, okay, at time after 4 hours at time of vaginal examination. What about the medication? Record the oxytocin is given or not, units per liter and drops per minute. If no, write no. If the woman is receiving any medication, right, for example, 50 milligram pethidine IM. If the woman has IV fluid, record yes or no. And overall assessment for her condition. Is this a normal progress of labor, or it is a poor progress, or there is fetal compromise, or if there is any other concern. For example, the plan, we can say that continue routine monitoring, prescribe diagnostic tests. For example, if the patient having late deceleration, you should do fetal blood sampling and according to clinical situation. If the patient having infrequent contraction, give oxytocin. Artificial rupture of membranes, if the patient have a prolonged labor with intact membranes. Assisted birth with vacuum or forceps if the woman is in fully dilated cervix and she is not delivering after 2 or 3 hours. Cesarean section, for example. And senior one should be informed the decision to ensure the well-being of the mother and the baby. Let's go back to other example. For example, no oxytocin, she's a spontaneous labor, no medication, no IV fluid given. Even when she transferred to the second stage, remain in the no. Pain relief is required here. Normal progress, normal progress, normal progress. We write this assessment at time of each examination. What about the plan here? Offer companionship, for example, continue routine observation, everything is well. What about our patient here? We see that the cervix remain for more than 3 hours. Here the head, the oxytocin is given 2 unit 15 drops. Pethidine is given. Here the assessment is there is meconium, so we should monitor the baby. Normal progress, continue routine care because normal things. And here we have poor progress because the cervix is not dilated well, in addition to molding, to caput and meconium. So poor progress, decision is to go for a cesarean delivery. And here the reference, I advise you to read WHO care guide, the user manual, and thank you for the good listening.